My name is Cécile Perrault. I'm a lecturer in mechanical engineering. And my research, my interest is on mechanical forces, specifically in the body and in the cardiovascular system. I want to see how mechanical forces influence the body, how it plays a role on cells and on tissues. And in a lot of cases now we have realized that mechanical forces are a contributing factor in the development of cardiovascular disease. So if we understand a little bit better what mechanical forces are doing on cells and in the body, it is a new route for therapeutic approaches in order to slow down the progress of the cardiovascular disease or even completely stop it. Now, intuitively, you know that the cardiovascular system is very dynamic. If you look, your blood is being pumped out of the heart on a cyclic rate. You've got a pulsatile flow going through the blood vessels. The blood vessels themselves are usually quite elastic. So in the arteries, you're going to have an opening and a closing of the vessels. And if you think about it, the endothelial cells, which are the innermost layer of those blood vessels, are exposed to a lot of mechanical forces. It is the shear stress due to the blood flowing on the top of the head, or it is also the stretching and the compression happening when the vessels open and close. So mechanical forces are very important for cells. Now, because a picture is worth 1,000 words, I'm quite fond of videos, and I've got the really cool videos of Professor Evans, a close collaborator, who's been proving that mechanical forces are very important on cells, on endothelial cells specifically. So what he's shown is that if you take endothelial cells and you put them on the surface and you start applying flow, which is what you have here, cells, and you're applying flow from the left to the right in here at 13 dynes per centimeter squared, and for the mechanical engineers, that's 1.3 pascals. And those are flow rates that you would find inside of the body. What you see is that on a flat surface, the cells will progress really nicely. They're not being hindered. And just to prove, hopefully it works, yes. As you can see that the cells on a surface and with flow will move nicely. Now if you put an obstacle like this, here, this is a ridge, so you all of a sudden have a step in it, the flow will be stopped by the step. You can imagine that the flow is going, it hits the step and it recirculates. The flow that barely makes it out of the step actually recirculates after the step. And what you can see is that the cells really don't like it. They don't want to stay in the regions of recirculations, and they can't escape in the back those zones of recirculations. So clearly, mechanical forces, and in this case shear stress, influence the way the cells behave. Now this is really interesting on its own for the science of it, but it also can be applied when you start thinking about stents. So we heard all at the beginning of Andy's talk about stents. Those are medical devices that are deployed inside of blood vessels that are getting clogged because you have too much of cholesterol. You've accumulated a plaque. And so what you do is you take a metallic mesh and you force it open. Now you can imagine the amount of force that's needed to deform metals. You have this balloon, it's applying a huge amount of pressure. You've got the cells inside of the vessel. They're not in a happy environment. You've got a plaque there. The body's trying to fight that plaque. So all of a sudden you come on those endothelial cells and, well, they're very not happy. You're deforming a balloon on the top of it. So what happens most of the time when you deploy those stents inside of the patient is underneath the stent, you've removed the endothelium. You've completely detached the endothelium. Now, that's not a good thing because the endothelial cells are used to dealing with the flow. The cells underneath, the smooth muscle cells, are not. So all of a sudden, their protective area is gone. They don't know how to deal with flow. They start sending signals. They're accumulating the immune system. They start interacting with platelets. You get clots. It's a problematic issue. So what you want to do is to repair this as fast as possible. Two ways the body deals with repairing. You can have either the neighboring endothelial cells coming in, kind of like the movie that we saw from Professor Evans. They can migrate from the surrounding areas and repair the endothelium. The second route is that you've got those circulating endothelial progenitor cells, pretty much baby endothelial cells, that come and attaching that area, turn into endothelial cells, repair the endothelium. So 2 ways to repair a stented vessel. Now I'm interested in hemodynamics. Those 2 ways will deal with 2 types of mechanical forces, 2 parameters. The migration of the endothelial cells will be using shear stress. So I need to look at the shear stress inside of those stent vessels to understand how will the migration progress. The circulating cells will need to be stopped, so the flow will need to bring them in contact with the surface. They would need to stop in a uniform way so that you can recover a full endothelium. And that's what we've been studying. So with the stents that Professor Gunn has been providing us, we've been deploying them in an artificial blood vessel that's completely transparent, made of silicone. It's the deployment like the doctors would do, which Andy explained is critical because you don't get a uniform deformation. And then once we've got this, we can deploy stents, cells, we can deploy particles to see what the flow is doing. Now, because I want to know even more information that's not necessarily available by testing, I can also scan this and create in silico models and then question what is the fluid dynamics doing inside of that stented vessel. The part of the presentation the part of our work I want to introduce to you actually came from Dr. Narita over in France. She saw our work on the stents and she started talking to us because she's an expert in deploying something called flow diverters. So stents originally were the first intravascular device, but medical doctors started applying them in a lot of different situations that were not made for stents. And one of the cases was aneurysm. An aneurysm is an expansion of the vessel in reactions to disturbance in the flow. What the doctor started doing was putting a lot of stents on the top of each other so that the flow wouldn't happen inside of the aneurysms. As a result, the aneurysm clots and resorbs. Obviously, medical device companies said, oh, you don't have to do that, we'll create a device for you. And they created something called flow diverters, which is a mesh, but much more dense than a stent. Now, because the stents have been on the market much longer than the flow diverters, we know how the body reacts to it. So we know which cocktail of drugs to give to the patient so that they don't react badly to the stents. When the flow diverters came on the market, and we're talking 2008, 2010, so fairly recently, they said, we'll give the same exact cocktail of drugs to the patients. Whether you're given a flow diverter or stent, we'll give you the same treatment. Now, Dr. Narita came and said, I don't think that's a valid answer. I don't think we have the perfect solution there. Because if you think about it, we're not looking at the same thing. A coronary stent will be a metal cylinder that's been laser etched with that pattern. A flow diverters is actually a lot of wires that were meshed together. The coronary stent, if you remember that step I was showing in the video from Professor Evans, that step is usually 50 microns. In a flow diverter, it's less than 20 microns. So we're dealing with an environment that's completely different. And she wanted us to look at the hemodynamics of flow diverters to say, is it the same environment? Actually, are we disturbing the body as much? So that's what we started doing. So in the case of coronary stents, those are all different type of coronary stents. We started looking how much does it disturb the flow. If I put particles through it, is it actually, challenging them? And you can clearly see, depending on which design you're looking at, you're going to have different patterns of particles. What's really interesting also is that in a lot of cases, you've got a funneling effect. It's quite dramatic here in this one, where any particles that were floating next to the stent were being funneled into one single line. And now you think about your endothelial progenitor cells that are floating around in the blood, and you're thinking, oh, everybody's going into one single line. So you're going to have one region that's going to get tons of repairing cells, but the rest is not. So that's interesting. And it's quite interesting that the design of stents is not taking that into account. And this is what we were seeing with the flow diverters. Actually, no deviation of flow at all. So you're getting a much better distribution of the cells. If you're looking also in particle accumulations, in an empty tube, you don't see a lot of particles being stopped. In a coronary stent, you see clearly that the design will lead to more cells attaching to the struts. And in a flow diverter, it's more uniform, it's more diverse. So then you don't have at all the same environment that your body is dealing with. And then the shear stress, which is the one that we're looking for the migration of the endothelial cells, also look completely different. What you can see is that the design of the stents will create regions of very high gradients of shear stress, while on the flow diverters, the gradients are smoother and more distributed. So we're talking two complete different hemodynamic environments inside of the blood vessels. So in short, I hope I've shown you that the hemodynamic environment of coronary stents is highly dependent on the design of those stents, and that is not something that the medical device companies are taking into account at the moment. That this environment, this physical environment, will actually influence the way your body is repairing due to the behavior of cells under stimulations, and that flow diverters are not the same thing than coronary stents, and we should not give the same post-operative treatment to patients when it's a flow diverter and a coronary stent. Thank you very much.
Okay, thank you, Cécile. What you can't see is that she had a timer here, and it's just stopped on 11 minutes and 57 seconds, which is very good. Are there any questions?
Yes.
Cécile, that was a great talk, thank you. There's a cautionary tale, really. If only people had listened to you, spent billions developing the biodegradable scaffold. And this was hyped as the next great development in stenting. So it was designed to degrade to CO2 and water in the human coronary and disappear. Great concept. Everyone thought it was fantastic. The clinical trials showed a doubling of the stent thrombosis rate. Why? Sure, the thing dissolved over 2 years, but the stent struts were twice the thickness. If only they'd looked at your work.
And it's really interesting because it didn't even open the door to the hemodynamics question.
Exactly.
They're still not looking at it.
That has put back that the failure to grasp what in silico modelling could have told them for a fraction of the cost of a huge clinical trial is immeasurable. We've probably been put back 8 years in cardiology because of that. All the companies have pulled it. The FDA has said you're not implanting any more outside the clinical trial. And the whole biodegradable story is now on hold.
Yes, and it's not the biodegradable question, it's the hemodynamics.
It's the hemodynamics. It's what, cardiologists like me stick these things in and walk away and put the coffee on. That's when the biology starts, right?
Exactly.
Okay, one more question.
Two quick questions. What about drug-eluting stents? And the second is, what is the pressure gradient difference between an aortic aneurysm, where you're using one of those devices, the other device, and a coronary, where you've got a different pressure gradient?
Yes. So the first question, drug-eluting stents at the moment, it's a very interesting question because the drugs they're using a lot of times is to inhibit formation of clots. They're not looking actually to help the recovery of the endothelium. So that's one of the things that I think they should definitely look at. But it's not, the hemodynamics would be the same. And then your second question was?
Pressure gradient.
Oh, pressure gradients. So we have been looking at pressure gradients, and the pressure gradients are there, but they're not as significant on the effect of cells than shear stress. Shear stress seems to be a lot more important to the cells, they're using that a lot more as a director of their migration in our cases.
Right, one final question over here, I think.
Just a very quick one, just qualitatively looking at your results, there seems to be a difference between the stent, the coronary stent, and the flow diverter,
Yes.
in that more particles are getting trapped downstream of the flow. Is this significant?
Well, it is fairly significant. This is actually one of Bolt's flow diverters, and it was their first design, and we reported that to them, and they know that this end, if you can see, it's really roughly, it's because they mesh it and then they cut it. And they've been having report that that's problematic inside of patients. So now their new design, actually, they take the same wire and they twist it around instead of cutting it. And we get less particle accumulations as a result.
It's a real thing.
Yeah, it is a real thing. Yeah. Oh.
If it's quick.
Can cavitation occur in this phenomenon?
No, cavitations would need much higher Reynolds number, and so in those cases we don't see